Oh, Pat Travers, crash and burn. It would be hard to burn today. There's so much water. You might crash and drown here in Del Norton, Crescent City, but we're not going to do either. It is 10 minutes past the top of the hour. That hour is 11 a.m. You are tuned to KFUG, Crescent City 101.1 on your radio dial, worldwide on the internet, kfugradio.org. This is Public Process. I'm your host, Mike Thornton, and we are joined in the studio by Del Norton County's Public Health Officer, Dr. Warren Rehwaldt. Dr. Rehwaldt, thank you for being with us today.
Thank you.
Well, we really appreciate you coming in and hydroplaning across the parking lot to make it in here. So one of the things that we like to do on this program is not just talk about what you do, but also to find out who you are. So, if you were to be asked a question, which you're going to be asked, who are you? How did you come to, be involved in doing this work? And what are the things that motivate you to be a county health officer? How would you go about answering that?
Well, I'd start with just how I came to be in Del Norton County in the first place, I think. My wife and I are both family physicians. We both trained at the same residency in San Bernardino. I moved to California in 1989, and we moved up here together in 1992. My wife has been a community health physician with Open Door since we came here.
Oh, okay.
That was her first posting, and she only recently left it last year. The main reason was because she has to take care of her father, who's elderly and ailing. She still works a little bit part-time with them, especially because of what she does. Her main function at the clinic was running the Suboxone treatment program.
And for people who don't know what that is.
Suboxone is it's an office-based way of maintaining narcotics addicts free of narcotic addiction. So it substitutes for whatever they would normally be buying on the street, such as heroin or prescription pills that they bought or acquired somehow.
So a maintenance program,
it's a maintenance program, exactly.
Which is designed to help people not have to go out and hustle for heroin on the streets, basically.
Yes, yeah, exactly. And it's been very successful, been very popular. She's been running that for about 7 or 8 years. When I came here with her, my first posting was with United Indian Health. I was with them for about 5 years. I was their first physician in Del Norton County, and for the entire time I was here, I was their only physician in Del Norton County. I briefly went into private practice with Dr. Wayne Hawthorne. Some of your older listeners, maybe most of your listeners remember him. I was with his office for about 4 years. And during that time, I transitioned over to Open Door, where I have been for most of the last 15 years. I left as well in October of last year from Open Door to help my wife look after her dad mostly. And also I decided I was due for a sabbatical leave, a break. I'm taking some time off. I'm actually going to be starting an acupuncture training course later this month.
Oh, that's I know from some past work I've done with people that, and not saying yours is connected to that, but that acupuncture has also been used pretty successfully in drug detox.
Yes,
yeah.
It has a wide variety of applications. It's pretty useful.
So you left Open Door and you're getting ready to do acupuncture?
Yes. And in the meantime, I'm the health officer. I've been health officer twice. I started the first time about 6 months before 9/11. I took over from Dr. Rich Mize, who probably a lot of folks will still remember. I stayed in the position till about 2005, 2006. I don't remember for sure anymore. Our Open Door, the Del Norton Community Health Center, was getting very busy at that time because we were very short-handed. A lot of people probably remember 2005 as being kind of the year that everybody left Del Norton County in the medical field. We lost about half the physician workforce across the board in Del Norton County.
So I wasn't here at that time. Can you talk a little bit more about what happened and why that happened?
Well, I think it was kind of the perfect storm of bad luck for the most part. We lost some physicians in private offices, And at the community health center, we lost about 70% of our provider workforce in the span of about 8 or 9 months. I think some of it, people had been planning for a while to leave. I think 1 or 2 people were just unhappy with their job or what they were trying to do. And it just kind of took on a snowball effect, kind of rolling down the hill, and everybody decided to drop out at the same time. At one point, it was my wife and myself and 1 nurse practitioner were all that was left.
Part of the reason why I'm focusing on that is that I hear very often about the difficulty that we have in recruiting medical personnel and doctors to this area. It's a real challenge. It sounds like it's been a challenge for a while.
It has been. As long as I've been here, it's been a challenge. And the thing we've learned the most is that most people who come to a place like this, they come here because they have a unique interest in living outdoors, living in rural communities. They're not really geared towards considering a big city environment or even a medium-sized city as a place to practice. Unfortunately, that's a minority of most of the applicants, maybe 1 in 10. That's kind of what I concluded years ago after trying to recruit for dozens of positions. Maybe 10% of the time we'll find someone who really looks forward to coming to a place like this. Most of the time people come and check it out and then they end up going somewhere else.
Are there particular challenges to rural medicine? Or is it, and it's probably, my guess is it could very well be both. I mean, I was familiar with the area before I came here to take a job. And I have to say that after being here for a little while, I didn't have a full appreciation of how isolated it really was, even though I was familiar with the area. So is it that and or particular challenges related to practicing medicine in a rural area? Does that make sense what I'm asking?
Yes. It's 2 things. I think part of it is just the quality of life issue, which is what you're kind of driving towards here, I think. If someone is leaving a training program, usually it's in a bigger city environment. There's a lot more stuff going on. They're usually young people, relatively young, late 20s or 30s. They want to avail themselves of all that stuff that's going on in a big city. Coming here is a bit of culture shock because you don't have the same level of music events and just all the things that go along with living in a big city.
Right.
So I think it's a harder adjustment, and I think it creates a little bit of hesitancy on people when they're coming to decide, where do I want to practice, where do I want to go work, what office do I want to work with. In terms of what people actually do day to day in the medical field, a small community like this has a whole different level of challenge just based on the resources that you're accustomed to, especially if you're in a training program. You're used to having specialists basically within walking distance almost all the time. Most big hospitals are fully equipped to offer all the specialty services that people need to understand in order to learn how to do their jobs. As certainly in primary care, you need to understand that. Here, sometimes the closest specialist is hundreds of miles away. And just the fact that at least a couple months out of the year, it's pretty risky to travel some of those roads to get to those specialists make it even harder. So people kind of come and check us out, and they ask us a lot of those kind of questions. How hard is it to get a referral to this kind of doctor or that kind of specialist? And we have to be honest and tell them it's really hard, and that makes it more of a challenge to recruit as well.
We're speaking with Dr. Warren Rehwaldt. He is the Del Norte County Health Officer. You are tuned to KFUG Crescent City, 101.1 on your FM radio dial, worldwide on the internet, kfugradio.org. I'm Mike Thornton. 19 minutes past the top of the hour. This is Public Process. So, Dr. Rehwaldt, I think a lot of times, at least for me, I think in terms, because I'm one of those people that if I have to go see a specialist, I have to travel hundreds of miles to do that. I often think of it in terms of how it affects the person in need of health care. I don't often think about it as it affects the healthcare provider. And so it sounds like there are effects on the healthcare provider as well.
Absolutely. It makes a big difference, especially when you're just starting out. My perspective is a little different now because I've been practicing in this community since 1992 in one capacity or another. So I'm used to it. But when you're a new provider coming fresh out of training and you come to a community like ours where specialists literally are hundreds of miles away or at least an hour away, it's a different feeling, and it does create it creates a level of anxiety that people are not really looking forward to.
So let's, if we can, kind of move into talking about public health, the public health department, and the role of a public health officer. So when we're talking about public health, what is your interpretation and vision of that?
Well, public health touches people's lives in a lot of ways that they're not aware of. So in some ways, public health does its best job when people don't think about it so much. A lot of the traditional public health roles of checking for sanitation, healthy food, following disease outbreaks, things like that, that's been well established. Sometimes that becomes a very public issue. If you have something new in the community, a new disease that people need to be warned of, it needs to get out there. So we're always kind of in the background of those things. I think what has changed a lot over the last 30 or 40 years is more of the role of public health as an education method, as a way of trying to improve people's health through better information. That wasn't really part of the traditional public health model so much. I'm going to give an example from clinical medicine. When I was in training, the idea of using gloves when you're with patient contact was foreign. It was really just getting started. In specialized cases, people were told, yes, you need to start using gloves. But even when I was still in training, even though HIV had been around for several years at least and been identified for quite a while, it was not widespread. It took physicians and practitioners in hospitals literally decades after that to understand just the concept of washing hands. So that's a public health kind of issue that is both clinical and public. The idea of just hand hygiene for professionals, not just the public at large, but for professionals conducting their daily business, took a long time to change people's minds. I'll give another example of public health as an educational tool. Back in the 1960s is about when the program against smoking, against tobacco use, really started in the United States. And back then, half or more than half the population smoked. And it has taken that long to get the population down to 20% or less as smokers. And it was a huge process, huge, slow public process at multiple levels, at the federal level, at the state level, at local health departments. We still have an active tobacco use prevention program. We have staff at the health department right now who work in it every day. So some things are ongoing and they never stop. And then there's always new things on the horizon that come up. Part of what we do also is just what we've been talking about with community health. You know, when as a physician at the Del Norte Community Health Center, I'm considered a community health physician. So I work to support a clinic. I work within a clinic that is serving the underserved and the neediest people in the community. Part of public health's mission across the country is to make sure that happens. There are health departments around the country that do that directly. For example, Los Angeles County Health Department is huge. They run
has its own governmental run.
Basically, it's a huge budget. It's a giant department within the county system in Los Angeles. They run hospitals, they run clinics, they have huge numbers of staff. Del Norte, we have 4 health nurses And myself, I'm a very part-time health officer. I work, ideally, I'd work about 1 day a week as a health officer. My employment agreement is actually less than that, half a day to 1 day a week. So it kind of is scaled on how big it is. But we all have a little bit of that same function, just making sure that there is a health system for the needy and underserved. In Delnor County, it's been kind of de facto. It's been the open door system. Delnor Community Health Center, Sutter Health Clinics has added to that. United Indian Health Services has been alongside the Delnor Community Health Center all these years, serving the Native American population. So we have it well established. It's just not coming from the county level.
We're talking with Dr. Warren Rehwaldt. He is the county health officer for Del Norte County. You're tuned to KFUG Crescent City. This is Public Process. I'm Mike Thornton. Doctor, a couple of questions come to my mind as I'm listening to you speak. The first two are, so it seems like government, which I know for some people is a dirty word. I think when it functions well, it's not. That's my opinion. Seem to be really, over a period of time, engaging in ensuring food safety, those kinds of things. I fear that there is a real rollback of those kinds of things going on, and that more and more of the responsibility for ensuring that those types of things are being done to protect public health are being put in the hands of industry, and it is in industry's interest to cut costs however they can. So my first question is that an increasing pressure on protecting public health?
I wouldn't say so in food safety. I think that system is pretty solid. I'm constantly getting notifications from the state about food recalls that we try and track down to see if any of our local outlets have any of the products that they're recalling. That's an ongoing thing. I don't think that has been affected in any way by industry pressure. I think what happens more often is we see problems with, I'll give you an example. The measles outbreak, for example.
Which is definitely something I wanted to talk about.
There is no industry pressure to stop vaccination of children. It becomes a public perception issue about whether children should be vaccinated, whether people should be vaccinated or not. That's something that it can affect what we do because it breaks down that kind of, it's what we call herd immunity, that kind of seamless protection that everybody has by virtue of the fact that everybody around them is vaccinated. I see that a lot more in today's public health world than I see economic pressures from specific industries.
Well, since we're in the topic of vaccines, let's go ahead and go with that. One of the reasons I particularly wanted to ask you to be on is I've been in other communities where I have seen this sort of anti-vaccine conspiracy stuff take hold, and the next thing you know, you have outbreaks of particularly preventable childhood diseases and things like that. I'm seeing that kind of stuff happening on local Facebook pages here as well. Let's talk about vaccines. Are they safe? Do they cause autism? What about herd immunity? What does that really mean? And what does this anti-vaccine movement do when it comes to being able to protect public health from these various types of communicable diseases?
Sure. Well, the short answer is they are safe. They don't cause autism. There are listeners probably listening to your program today are going to be shaking their heads when I say that, but it's still true. The person who started this was a British researcher, I think back in about 1998, 1999. He later retracted his research. He went around the world and said, I faked this. I fudged the data. It's not true. But people still believe that the connection is there. There was a big study published out of Australia just this last year that surveyed 80 or 90,000 individuals and found no connection. I mean, it's just not there. Having said that, immunizations have been a tough sell for a long time. And the reason is, especially with childhood immunizations, you're asking parents to go into a room, a clinical room, and have people stick needles into your child and make them cry.
Sure.
And then you take them home and they are fussy and feel a little feverish or maybe a little swelling at the injection site. And you're worried about that. You're scared about that. I'm a parent too. My wife actually refused. She's a doctor. My wife refused to take our children, our two boys, to their child visits because she didn't want to be the one sitting there holding our crying son. So I've sat through that. I was the one who took them. And it's hard. Even me as a doctor, it's still hard to watch. I understand that. Everybody gets that. But what people have forgotten is all the things that have changed because of vaccination, or have never learned all the things that have changed because of vaccination. We were able to say reliably in this country that we had no more measles that was endemic, that was within our borders and stayed within our borders as of about 2000 or so. It's been almost 20 years. So the measles outbreaks we have now are brought to us from other countries whose vaccination programs aren't as effective.
Right.
And the reason they take hold is because some people out there are not vaccinating kids. They're choosing not to do that. They're making a decision for their children. Those kids are susceptible to the disease, so they get it when they get exposed. Measles is very infectious. It's probably maybe the most infectious organism out there in the world. You can sit in a room with someone literally for a few minutes and you're at risk for infection. And if you sit in a room with someone who's infected for more than a few hours, you're guaranteed to get it. That's how bad measles can be. So measles outbreaks are happening because we have little pockets of people. There are enough people within a community who are not vaccinated that if someone comes back from a different country and they are an active disease carrier, or they have the disease, or they're recovering from the disease, but they still have the measles virus coming out of them, they can start an outbreak. And that's how it happens in our country now. That's the only way it really happens anymore.
One of the things that I find really, I was going to use the word interesting, but that's really not the word I want to use. I think I want to use the word amazing, is that most of the time that we're talking about parents who are advocating against vaccines or not vaccinating their kids, these are not parents who don't have access to information. Very often we're talking about, reasonably affluent people who have, I think, access maybe to too much information, or certainly the wrong information. Does that make sense?
Yes.
Yeah, because I please speak to that.
Well, again, I think for a lot of people, it's a matter of principle. They think of what's natural for humans to have. And if you think about it, a vaccination is not a natural thing. You're putting something in someone's body to create an effect that's going to protect them down the road. And resistance to vaccines is not new. It goes back to the middle part of the last century when widespread vaccination got started. I mean, I'm old enough to remember getting vaccinated in school.
Sure, me too.
And it was a hotbed issue back then. There were a lot of parents who were saying, well, why do we have to do this? The culture was different. I think most people went along with it, didn't really question it as much. And part of the reason, again, was just what was prevalent in the community's knowledge base at the time. Because back then, we still had a lot of people who were recovering from polio.
Yes.
The eradication of polio started in the 50s with the first vaccine against polio. And before that, it crippled people. And it was widespread. And measles, before it was eradicated here, caused maybe 500,000 cases a year. And measles can be very serious in some people. They can develop an encephalitis from it, and it can kill them. Doesn't happen very often. It's considered a routine childhood illness, but the consequences of measles back then was much, much worse. And people don't remember that now because it's not happening now, except for these little outbreaks. People don't remember polio now because it doesn't happen now. Well, in fact, we had to, a few years back, we had to switch from the oral polio vaccine, which was a pill. And that was designed to save kids from getting that extra shot so they wouldn't cry so much. We had to switch back from oral polio to injected polio because the only people who were getting polio were people who were immunocompromised. Their immune system was not functioning well enough to fight it off. And the oral polio, what it was a modified version of the virus that stayed in people's gut. So they actually would poop it out of them. They'd spread it a little bit just by normal casual contact. And it was just too risky to go on using. So we had to switch back to the injected polio version.
We're talking with Dr. Warren Rehwaldt. He is the county health officer for Del Norte County. You are tuned to KFUG Crescent City, 101.1 on your FM radio dial, worldwide on the internet, kfugradio.org. This is Public Process. I'm your host, Mike Thornton. You talked about people who are immunocompromised. And this gets to, for me at least, the topic of herd immunity, because as I understand it, there are a number of people for a number of different reasons who cannot be vaccinated.
That's correct.
Speak to that and why herd immunity is so important.
Well, herd immunity is the idea that if you have enough people vaccinated in a community, you don't have a way for a disease to take hold. And I like the analogy of a forest fire. So if you have a really dry forest right next to a really wet forest, and that forest fire is burning up to the border of the two forests, and we all know how forest fires progress. They send out spot fires and embers ahead of the fire, and it creates little pockets of fire. The dry forest burns freely, but it gets to that wet boundary, and those spot fires, they just don't take hold. So herd immunity is a little bit like that. If you have someone in a community who's infected with something, but there's nowhere to pass the infectious organism onto because everyone around that person is been immunized, they've been vaccinated, so they get exposed and they don't get the disease, then it has nowhere for the disease to go. And that is the key protection for people who are immunocompromised, because if you can't get a vaccine, either allergic to it or it just won't take because you're immunocompromised, or you've been vaccinated but because your immune system isn't working well anymore, it doesn't work anymore. The best protection you have is to be around people who are not sick or not going to become sick. So vaccination does that. It really creates that environment, that kind of healthy environment that people can live in. And that's the thing that I think has not been talked about enough, is how big a difference there is over the last 20 or 30 years in medicine in terms of the numbers of people who are living with an immune compromised condition. So in other words, there are more people on cancer with chemotherapy. There are more people living with chronic immune disorders that we didn't understand back 50, 60 years ago, but we are able to keep them going now. And so there's just more people out there at risk than there were before.
Well, it's interesting because it doesn't have to be something as big as cancer. I have psoriasis. And up until, of course, I went on Medicare, I was taking a drug called Humira, which is also an immunosuppressant. And, I was told that there were things that I couldn't do or shouldn't do because I'm taking this drug, which is suppressing my immune system. So there's all kinds of that thing going on, and most people don't realize it, is what I'm hearing you say.
That's exactly right. And the resistance, if the resistance to a vaccine is a philosophical thing, you have to. The question needs to be asked: am I doing my community a favor by not vaccinating my children, myself? Am I going to be the one that's going to cause someone to contract an illness when I get sick? They contract it from me. That calculation really should go into every decision about vaccinating or not vaccinating. And here, the other thing about it is, there have been some cases where vaccinations have not gone well.
Well, and I wanted to get to that.
That has also kind of made this issue harder to cope with now.
Speak more to that, if you will.
Well, the one that comes to mind the easiest is the swine flu pandemic back in the mid-1970s. I think it was 75 or 76. They vaccinated about 40 million people, trying to prevent a disease outbreak that never took hold. It started, I think, on an Army base or a Navy base. A few people came down with this flu. They identified the flu through the laboratory analysis, and they realized it was a new strain that they hadn't seen before. The people in charge at the time were very worried that it was going to be a widespread outbreak. It would take over the country, and maybe millions of people would become infected and be at risk of severe consequences from it. They decided to go ahead with the vaccination. The vaccination program was done, but the flu never really materialized, and there was a big time interval between identifying it and getting the vaccination done, and it just didn't happen. And the hard part about it is that some people had some consequences of the flu, of the flu vaccine. There was reportedly a few people, I guess, who died early on after their vaccination. It wasn't really clear that they died from the vaccination, but that got out into the press, and people became very upset about it. It was a whole fiasco of events that centered around this vaccination program. And I think most people thought it was, in the end, that it had been handled kind of badly, and it had wasted some time and some effort.
We're talking with Dr. Warren Rehwaldt, County Health Officer for Del Norte County. This is Public Process. I'm your host, Mike Thornton. Doctor, that makes me think of something that I see get circulated, that there is, and excuse me if I've got this wrong, some sort of vaccine compensation fund. And in my understanding, at least from looking at the CDC site, that there is money that's paid out related to people engaging in legal action related to vaccines, but that very rarely is it ever proven that any of that money actually had anything to do with the vaccine, that most of those cases are settled well prior to that. Do I have that right, or am I talking about something that you're not particularly familiar with?
You're getting into legal territory that
I'm not talking so much about the legal aspect of it. I see some people who I know post this stuff on Facebook, right? And it says, oh, look, X amount of money was paid out. But then when you dive a little deeper into the data, it's like, well, okay, there were like 1,000 cases out of 4.5 billion vaccinations, and that they say, oh, well, money was paid out. Well, okay. And then you look and it says that the cases were settled mostly, I think, to just say, you know what, it's cheaper for us to pay it than not.
I think that often happens in a lot of industries, including pharmaceuticals. Yeah. That brings up a point. The swine flu case that I was talking about a minute ago, one of the chief consequences that people heard about was a condition called Guillain-Barré syndrome, which is a paralysis that takes hold usually after a virus, sometimes after a bacterial infection. It's not a common thing. It happens, I think, on the order of maybe one case per 100,000 people per year. There were about 1,000 cases that particular year of the vaccine program. About half of them happened before the vaccines, and about half happened afterwards. And it raised the rate from one case to maybe 2 cases overall. So people were speculating that maybe the vaccine had caused that. Now Guillain-Barré, as long as I've been in practice, is listed as a potential side effect of every influenza vaccine, probably for that reason, because of that experience. It's not clear to anybody looking back over the data from that time period that there was a clear connection between the two. You can't always prove that, but it did seem to show a slight difference. That is the sort of information that takes hold of people's consciousness, though. It's like, I'm putting myself at risk for some horrible disease by doing this, without thinking of the prevention of the disease, or the horribleness of the disease that they are trying to prevent by the vaccine.
And as you said earlier, because I remember I took my granddaughter in to get vaccinated, and she came out after getting vaccinated. She was really torqued about it. She goes, Papa, that nurse is a brat. She gave me a shot. And it's like, and who wants to, and if you think there's even the slightest possibility, do I want to take that risk with my kids? I mean, I understand that, and then of course at the same time, it's like, well, what is the reality of this situation? We're speaking with Dr. Warren Rehwaldt. He's the County Health Officer for Del Norte County. This is KFUG, Crescent City. I'd like like us to talk about the community health assessment, if we can, that's been going on.
Sure.
I found it very interesting. And talk, if you will, about it from your perspective and what is the desired outcome of all this?
Well, the desired outcome is to understand not only the data that we have about our community better, but understand people's perceptions about the health of the community and their own health or the health of their neighbors within the community. We are doing it as part of a process. What started the process was to get accredited, which is something relatively new in public health circles, but accreditation is establishing a certain standard of function for a health department. It's become kind of the vogue thing in public health in the last 10 years or so. Most of the counties in California have applied or are in the process of applying for accreditation. We are probably one of the last ones to do it, mostly because of our size. Small departments have a tougher time doing this, just getting the process done. We also started a process for improving a oral health program, so dentistry and especially childhood dentistry. So the two seem to match together. We decided to run them more or less simultaneously. The first step of accreditation is to do a community health assessment.
Okay.
So that's where we are. The next step is to develop a plan to improve the community health in some measurable ways based on the information we get from the first step. So right now we're collecting data. We've got, the survey tools are out there in paper form. They're online. We have the comment boards. We've had some meetings sponsored in various communities in the county. That's still ongoing. We're going to be trying to wrap most of this stage of it up within the next month or so. We're working with some consultants from the Bay Area who've worked with small counties around California for this process as well. They're kind of helping us stay on track with it, give us some guidance. They're helping with a lot of the data collection that's hard for us to do. There's a lot of information out there, but you have to know where to look and how to manage it, and that's their role.
And it seems to me that getting the perspective of the individuals in the community is incredibly important, because how the professionals or the elected officials or the appointed officials see it may not necessarily be the same way that the community as a whole sees it.
That's absolutely true. And it struck us when we started this that we've never done a community-wide assessment through the health department before. We've done needs assessments for various programs within public health and within social services. But a broad approach like this, where we're asking for input just randomly off the street or at public meetings of people meeting with us, that's never been tried before. So it's kind of exciting for us because we're really seeing some interesting comments and some good data is starting to show up, and we think it's going to be very helpful.
So I want to segue. We have about 10 minutes left or so, and I'd like to segue, if I can, into one of my pet issues, pet peeves, whatever you want to call it, is the effect of poverty on health, the effect of homelessness on health. And can you speak to those issues? Because I find those to be not just in this community, but issues that broadly and deeply affect the health of many of our friends, neighbors, brothers, and sisters. And how does that get looked at from a public health perspective? Does that make sense, what I'm asking?
Yes. It's very clear that poverty by itself is probably the strongest predictor of poor health. The public health data has been showing that for quite some time. So there's no question about it. Homelessness is a category within that. Most homeless people are poverty stricken.
Sure.
They're certainly not wealthy. their health outcomes are adversely affected by being homeless. There's no question about that either. And speaking as someone who's worked in a community health center, I've taken care of plenty of people who are homeless for years, and I've seen it firsthand. So there's no doubt in my mind. Changing that is a society-wide issue. Trying to improve the economics that people have to deal with on a daily basis, that's tough. And their public health part of that is to do exactly what they've been doing, which is say, yes, health will be better if people are less economically deprived. People will do better in general if they are not living in poverty. It's just a given.
I know in some communities they have approached people without shelter as primarily a healthcare issue, and the phrase "housing is healthcare" has been used in many communities. What are your thoughts on that?
I think it's probably very true. I think if people have a place to live, especially a safe place to live, they're going to do better across the board. They're going to be less likely to have bad things happen because of the routine kinds of things that people deal with, like the flu or pneumonia. They're just going to do better. On the average, people will do better. But it also changes their outlook on life, and it will, if they have, especially if they suffer from mental illnesses, it helps mental illness make it more treatable, more manageable, just by having a safe place to stay.
Well, and I'm not an economist, I'm not a doctor, I'm not a sociologist. It also saves a boatload of money and a boatload of effort and time.
Yes, I would agree with that.
We're talking with Dr. Warren Rehwaldt. He's the county health officer for Del Norte County. You are tuned to KFUG Crescent City, 101.1 on your FM radio dial, worldwide on the internet, kfugradio.org. I'm your host, Mike Thornton. Doctor, we just have a few minutes left, and I'd like to ask you, do you have any, final thoughts or issues that you want to make sure that we raise in these final moments?
I think people should get vaccinated.
Okay, that's a good place to start.
I can't emphasize it enough. I mean, people don't know what living with smallpox was like. Even our generation, we're old enough to remember getting vaccinated for smallpox.
Right.
I think people really should, if there's a question about vaccination, if they're having a philosophical dilemma or they're thinking that for whatever personal reasons they don't want to see their children vaccinated, they should really research what is different now after vaccines have been widespread around the world compared to 150 years ago when they weren't, and understand how much has changed and how many more people survive just by virtue of this simple process, relatively simple process. I personally wish that we had a better way of delivering vaccines. I think I'm not alone in that. It's been talked about for years, and especially in pediatrics, because pediatricians cope with this the most. If we could find better ways of vaccinating without poking needles in arms and legs and making babies cry, I think a lot of this issue would go away.
I'm just curious, what would a better way of vaccinating look like? I mean, I'm guessing you have some thoughts on this.
Well, the easiest way was, we talked about earlier, the oral polio, which we used widely for many years, and then we ended up giving it up simply because the only infections we were getting were people who were getting infected just from spontaneous exposure to the vaccine around them. If we had something equivalent, something very similar that we could use for other vaccines, if there were a way to do it without injecting needles, if we could do it with just a simple brush against the skin in some way, or something that was swallowed, something that was easier to administer, that was less hard on children, I think there'd be more acceptance among parents. I mean, realistically, there are a lot of shots that kids get. They have to sit through session after session after session, and yeah, granted, most of them are happening before they're even a year old, and they're not likely to ever remember any of it. But their parents and their siblings have to watch because they're usually in the room when it happens. And it's hard. It's a hard thing to go through, to see. And even the experts in the field who are the huge promoters of vaccination, they recognize that it's what we call the shot burden. The burden of the number of shots that kids have to get is so big that it is in itself a reason why kids are not getting shots, because parents don't look forward to it. And it's understandable.
Dr. Warren Rehwaldt, County Health Officer for Del Norte County, thank you very much for joining us on KFUG and Public Process today. Really appreciate you coming in and braving the elements to do so, and hopefully we can have you on the program again at some point in the future. I've found this to be very informative, and I think our listeners probably have as well.
Thank you, Mike. It's been a pleasure being here.
Great. Thank you very much. We'll be back with more Public Process in a few minutes.